Hello, welcome to the audio slide presentation of our recent paper. I am Maria Jose Rosa from the Icahn School of Medicine at Mount Sinai. For the next 5 minutes, I will be discussing the findings published in our paper titled Prenatal Particulate Matter Exposure and Wheeze in Mexican Children, Effect Modification by Prenatal Psychosocial Stress. First, some background. Previous research has linked prenatal ambient air pollution exposure to respiratory morbidity later in childhood, like wheeze, asthma, and reduced lung function. Prenatal maternal stress and stress correlates also have been associated with child asthma and reduced lung function. Lower socioeconomic status populations are more susceptible to air pollution-related health effects, potentially due to accompanying stress. Pregnancy may be a particularly vulnerable period for ambient air pollution exposure and stress for the developing fetal respiratory system. Fetal lung development occurs through a complex orchestration of sequential biologic events, and there may be periods of time in which the fetus is more sensitive to toxic exposures. Synergistic effects of traffic-related air pollution and stress on asthma incidence and decrements in lung function have been demonstrated in older children. While the programming effects of both air pollution and psychological stress on respiratory outcomes are thought to start in utero, no prior study had examined the joint effects of these exposures during pregnancy. We took advantage of data from an ongoing longitudinal birth cohort in Mexico City, the Programming Research in Obesity, Growth, Environment, and Social Stressor study in order to address this research gap. We examined the association between ambient air pollution average over trimesters and reported wheeze in children followed to 48 months of age. We also examined whether these associations were modified by prenatal psychosocial stress. In this study, we used novel geostatistical methods incorporating satellite-derived data measurements, geographic information systems, meteorology, and land use data to estimate very high-resolution daily particulate matter less than or equal to 2.5 microns in diameter, or PM2.5. We estimated personal level exposure for each cohort participant during pregnancy based on residence, and averaged it over clinically defined trimesters. Psychosocial stress in pregnancy was assessed using the Crisis and Family Systems Survey to obtain self-report of negative life events, or NLEs, occurring in the prior 6 months. The list asks questions about events over 11 life domains or categories depicted in this slide. Domains with one or more negative event were summed into a total NLE domain score with higher scores indicating greater stress. Using a version of the Standardized International Study of Asthma and Allergies in Childhood, or ISA questionnaire, which has been validated in children from Mexico, caregivers reported on respiratory outcomes in their children at the 48-month follow-up visit. We considered 2 outcomes. Ever wheeze, based on the item asking, has your child wheezed or whistled in the chest ever? And current wheeze, based on the item asking, has your child wheezed or whistled in the chest in the past 12 months? These analyses included 552 mothers and their children. Generalized additive models were used in order to examine dose-response relationships and allow the dependent variable to have a non-normal distribution. We classified women's stress level based on splitting the total NLE scores at the median, so that those experiencing events in 3 or fewer life domains were categorized as having low stress, and those reporting events in more than 3 life domains were categorized as having high stress. We also adjusted for child sex, mother's age, tobacco smoke exposure in the home, and maternal asthma. Models were also co-adjusted for all trimester and postnatal year 1 PM2.5. Shown here is the distribution of covariates, exposure, and outcomes across the sample as a whole, and then stratified by low and high stress as defined earlier. Sample characteristics did not differ significantly by stress level except for tobacco exposure, with a higher percentage of participants reporting a smoker in the home in the high stress group when compared to the low stress group, 43% versus 33% respectively. This slide shows the exposure-response relationship between average first trimester PM2.5 exposure in mothers and the likelihood of current wheeze at age 48 months in the low-stress subgroup, having an NLE score less than or equal to 3 on the left, and in the high prenatal stress subgroup, having an NLE score greater than 3 on the right. These data show an increasing odds of current wheeze only in children whose mothers reported high stress during pregnancy after adjustment for covariates and other trimester exposures and postnatal year 1 exposure. We also report a significant interaction p-value. A similar pattern was observed for the ever wheeze outcome, but the p-value for interaction did not reach statistical significance. We concluded the following from this analysis. Children born to mothers exposed to higher levels of particular air pollution during early pregnancy, specifically the first trimester, were at greater risk of wheeze by age 4 years, particularly if mothers also experienced more toxic levels of stress prenatally. Knowledge of interactions between chemical and non-chemical environmental toxins can better inform prevention and intervention strategies that may preclude persistence of symptoms or lung function deficits in later childhood.